Today we will talk about digoxin toxicity as a cause of hyperkalemia. So how digoxin can cause hyperkalemia, how we should treat it. So first of all, let's talk about how digoxin works. So if you have a cell, this cell is myocardial cell or musculoskeletal cell, and you have sodium potassium ATPase, and this channel will bring potassium inside and sodium outside. If you have digoxin, so the digoxin will have negative effect on this channel and prevent the potassium getting inside the cell, and as a consequence potassium will be high in the serum or blood, and also the sodium will not be able to get out of the cell, and the sodium inside the cell will be high, and this will inhibit another channel that should bring sodium inside and calcium outside. So as a consequence, the calcium concentration will be high inside the cell. So digoxin effect on the myocardial cell, it will increase intracellular calcium, and this will have positive ionotropic effect. This is why they use it sometimes to treat increase ionotropic effect and treat heart failure. Also, digoxin will increase intracellular sodium and decrease intracellular potassium in a way that can be tolerated. Okay. Also, digoxin have positive effect on the vagus nerve, so as a consequence it has negative chronotropic effect and will decrease the heart rate, and this is why digoxin can be used sometimes in the treatment of Afib with RVR. So this is the normal mechanism of action of digoxin. If you are having digoxin toxicity, what happens? In digoxin toxicity, there will be more negative chronotropic effect, more stimulation of the vagus nerve, and this will cause bradycardia and hypotension. So there will be bradycardia, there will be hypotension, there will be negative chronotropic effect. Also, there will be more electrolyte disturbance inside the myocardial cell, more sodium inside, more calcium inside, less potassium inside. This will induce ventricular tachyarrhythmia or ventricular arrhythmias in general. So digoxin toxicity can cause hemodynamic instability by different mechanisms. Also, digoxin toxicity clinical picture can cause GI symptoms, nausea, vomiting, diarrhea, can cause neuro symptoms, confusion, disorientation, can cause eye symptoms, yellow and green halos, can cause hemodynamic instability, and the hemodynamic instability is explained as you see here: severe brady hypotension or ventricular arrhythmias. This is how digoxin can be toxic. So what is the treatment for digoxin toxicity? Usually if we have hyperkalemia, we give calcium, right? Here, don't give calcium salts, don't give insulin or any medications that lower potassium level, which is strange. I told you hyperkalemia management in digoxin toxicity is very different. And also don't do dialysis. So why I cannot do any of that? So usually in hyperkalemia I can do all of that. In digoxin toxicity I cannot, or it's not recommended. Why? Because the digoxin increases calcium concentration inside the cell as explained here. So there is a lot of calcium inside the cell already. So when you are giving calcium, Usually we give calcium for myocardial stability, so we increase calcium concentration inside the cell to prevent arrhythmia, but there is already a lot of calcium inside the cell. So there is no need to more calcium, because this can cause very high intracellular calcium concentration, and this can be toxic. So don't give calcium. We don't give insulin and any medications that lower potassium because of many reasons. One of the reasons is when you give Dig Fab, which is the treatment for hyperkalemia. When you give Dig Fab, which is a treatment for hyperkalemia, the Dig Fab will lower potassium so fast. So it will lower the potassium fast. So if it will lower the potassium already fast, and you give insulin and other medications that will lower the potassium can go down very fast, and this can be dangerous. Okay, and that's why we don't prefer giving or any of these medications with the Dig Fab. The other reason also is but hyperkalemia and digoxin toxicity is not a cause of increased mortality by itself. We use it most of the time as a prognostic way to see the digoxin toxicity. This is why we don't like giving insulin or any of these medications. Dialysis, we will discuss dialysis. Why we don't like dialysis? For two reasons. First reason, digoxin binds to tissue, and the free digoxin in the blood is very small. A small amount of digoxin in plasma, and if you do dialysis, you will get rid of a small amount of digoxin because most of it is attached to tissue. So no need for dialysis. It's not beneficial in digoxin toxicity. The second thing is when you give Dig Fab and Dig Fab attached to digoxin, this and cause or make or creates digoxin Dig Fab complexes. This complex is very large and cannot be cleared through dialysis, and it can be cleared through kidneys. So your kidney are working fine, and it will take care of that and will get the digoxin Dig Fab complex outside, but dialysis machine doesn't do that. So if the patient has ESRD on hemodialysis, this is a special population, because if this patient doesn't have kidneys to get rid of the complexes, the large Dig Fab digoxin complexes, and they also dialysis doesn't clean or clear the Dig Fab digoxin complexes. So in this situation, after 10 days, there will be degradation of the Dig Fab digoxin complex, and the patient will have high digoxin again in blood and will have toxicity again. So the only way to resolve this is by having plasma exchange. So in normal people, their kidneys will get the digoxin Dig Fab complexes outside, but in ESRD on hemodialysis, dialysis cannot do that for them, so they should get plasma exchange. If they don't get it after 10 days, the Dig Fab will be degraded and digoxin will be elevated in the blood again, and the patient will have another episode of toxicity again. We will have some scenarios. So first of all, how much Dig Fab I should give for the patient? How much? So usually we start with 10 vials if we don't know the concentration. If we know the concentration, we calculated, it will be the concentration in nanogram per milliliter plus weight over 100. So for example, if the patient is 100 kilogram patient and the concentration of digoxin is 14 nanograms per milliliter, so the vials number will be 14 plus 100 over 100, so it will be 14 vials. This is how you calculate it. If you don't know, you just give 10 vials and you can repeat it again if the patient's clinical status or clinical picture doesn't improve. We will have another scenario. There is a patient, and this patient, let's say scenario number 1, this patient has history of Afib and the patient is taking digoxin, and the patient developed digoxin toxicity, and after that you gave the patient Dig Fab and the patient improved. That's amazing. Potassium level improved, everything improved, everything is going into the right direction. Hemodynamics, the patient is hemodynamically stable, everything is good. But out of the blue, the patient started having Afib with RVR. This is expected after giving Dig Fab, and you should be prepared and expecting it if the patient has already a history of Afib. Why? Because digoxin has negative chronotropic effect and lowers heart rate. So when you give Dig Fab, you will cause sudden decrease in the digoxin effect and sudden inhibition of the negative chronotropic effect, and this will cause high heart rate and the patient can have Afib with RVR. Okay, in this case you treat it as Afib with RVR. You stop giving more Dig Fab, and you can try to treat the Afib with RVR. Observe it after stopping giving Dig Fab. If it affects the hemodynamics and it's persistent, you can treat it. This is the first scenario. The second scenario, if you have a patient with history of CHF with ejection fraction of 35%, and this patient is taking digoxin and the patient had digoxin toxicity, and you give the patient Dig Fab and the condition improved, and after 2 hours the patient started having shortness of breath, and also the chest x-ray shows pulmonary edema. What is happening here? So in this condition, digoxin has positive ionotropic effect. So when you give Dig Fab, you inhibited the digoxin effect. So you inhibited the positive ionotropic effect. And when you give a lot of Dig Fab at the same time, and there will be sudden drop in the effect of the digoxin, this will cause negative ionotropic effect. And if the patient has already CHF, the patient may have CHF exacerbation and may develop cardiogenic shock, and the patient may develop hypotension also. So in this situation, you should stop giving Dig Fab. You should support the patient, give Lasix for the pulmonary edema. You can also give ionotropic medications to support the hypotension and the cardiogenic shock. Okay. After that, we will talk about some plants that may act like digoxin. What are these plants? Oleander and foxglove. So these two plants has chemicals that act like digoxin, so it can cause digoxin toxicity. When you get digoxin level on these in these plants toxicity, we use this digoxin level as qualitative, not quantitative. So don't trust the number of the digoxin level, because these chemicals are not digoxin, they are digoxin like chemicals. So when you measure digoxin level, it will give you a number, but it's not accurate. So use it as positive, negative. Don't use it as high or low, or don't use it to calculate how many vials. So for Dig Fab you give 10 vials, and if you need give more, give more. But don't calculate, don't trust the digoxin level in these plants. Also the same thing, don't give calcium, don't, as digoxin toxicity, don't give calcium, don't give insulin or other medications that lower the potassium level, don't use dialysis, and the only thing you can do, give Dig Fab. Okay, we'll have another scenario. We have digoxin toxicity, and the patient, because of the digoxin toxicity, is having bradycardia, having hypotension. We mentioned we can give, of course, Dig Fab to treat that. The question here, can you give atropine? Yes, you can give atropine. Can you start pacing? If you are waiting for Dig Fab and the pharmacy will send you the Dig Fab and it will take time, can you try pacing? Yeah, you can try pacing, but you should be so careful. Why you should be so careful? Because pacing, there is a lot of electrolyte disturbance inside the cell because of the digoxin. There is more sodium, more calcium, less potassium. So if you start pacing and there is a lot of electrolyte disturbance inside the myocardial cell, this may deteriorate it. So try atropine, maybe try pacing, but be so careful until you get the Dig Fab. The Dig Fab here is a definitive treatment. Okay, if you have digoxin toxicity and the patient has ventricular arrhythmia, you follow ACLS protocol. Okay, and the preferred medication here for anti-arrhythmic medication here, you can try phenytoin, you can try lidocaine. Okay, so I think we covered everything related to digoxin toxicity and the plants that look like digoxin, how to manage the bradycardia and hypotension, how to manage ventricular arrhythmia. We also talked about if the patient may have cardiogenic shock, the patient may have Afib with RVR after initiating the Dig Fab, how to calculate how much Dig Fab we should give to the patient, and why we don't like giving or starting dialysis on those patients, how digoxin work, and what is the clinical picture of that. So I think this is everything.